Hey, good morning. It's Wednesday, March the 1st. I'm Dr. Steve Stites, the Chief Medical Officer here at the University of Kansas Health System. Welcome to my favorite episode each month, Show Me the Science. It's where we take a deeper look at important and developing research. And I don't know that we can find a more important topic than we're talking about today, because we're going to talk about stroke. And before we dive into that important study that we're going to focus on, we want to show you what it really means for patients. One stroke survivor went from barely being able to wiggle his foot to walking his daughter down the aisle and sharing a father-daughter dance. Today, we're going to meet the man in those wedding photos and hear all about his recovery. Here with me now are two doctors who helped make that recovery possible. Dr. Colleen Lechtenberg is a neurologist and the medical director of the health system's Advanced Comprehensive Stroke Center. And Dr. Michael Abraham is the director of stroke research at the University of Kansas Medical Center and the co-author of the study we're going to focus on today. The SELECT-2 trial was published just 3 weeks ago in the New England Journal of Medicine. Its key question was, should patients with larger strokes get a thrombectomy? Okay, we're going to have to define all those terms, right? Big words. Thrombectomy is a procedure that removes a blood clot. This video gives you an idea of how it works. Doctors run a catheter through the blood vessel and they literally pull out the clot and restore blood flow to the brain. Dr. Lechtenberg, you've already been involved with using thrombectomies for smaller strokes, but traditionally, these big, large strokes have been off limits.
That's true. Patients with a large core have been underrepresented in clinical trials.
So a large core is that great big clot,
yep.
right?
No, it's a kind of a large area of completed stroke.
Okay, so just a bigger blood vessel and a bigger completed stroke that's affecting the brain and like a really big stroke that leaves you paralyzed on one side.
Sure.
Okay. And Dr. Abraham, you brought a catheter used for this thrombectomy. And I want to say it's kind of like picking a really big booger out of the nose, but not really. It's
kind of, yes.
But show us how that catheter works.
Yeah, so basically this is called an aspiration catheter. In Mr. Augustine's case, I ran it from the artery in his leg all the way around his aorta, literally into the brain to the level of the clot, and at the back end, I connected this to an aspiration tank which provided continuous suction or aspiration and literally sucked the clot out of his brain, restoring normal blood flow back into that area of the brain.
You know, my wife said sometimes she thinks I have blood sucking or brain sucking, loss of function. But in this case, we're restoring function by doing this. That's amazing.
Yeah, it's amazing technology that we have at our fingertips these days.
So, Dr. Lechtenberg, traditionally, what's been the medical care for a large stroke like this?
So the non-surgical medical management involves techniques to try and lessen the impact of the stroke and to prevent complications. That can be things like antiplatelet medications, anticoagulation, blood pressure management, medications to reduce edema, and things like that.
So we try to use some clot busters too, right? Get in there, and those sometimes worked and sometimes didn't.
Right, it's not terribly effective for the large clots in the brain that Dr. Abraham and his group will go after. So yes, the first line medical management when somebody comes in with acute stroke is thrombolysis.
Okay, so talk to me, what's a large stroke versus a small stroke?
So a large stroke, again, is where you have a large portion of that brain where the blood vessels blocked is already stroked out, meaning it's already damaged by the time the patient gets to KU Medical Center. And then a small stroke is just where a small area of the brain has stroked out. So the rest of the brain is at risk of stroking out, and that's why you have to move exceptionally fast to try to get the clot out and save the rest of the brain from stroking out. So what we see on these pictures right now, that is a CT perfusion scan. It's a specialized CAT scan that we do here at KU Medical Center that looks at the blood flow going into the brain. We can do this within a few minutes, but this picture, you see that dark purple on the one side of the brain, that is showing a large stroke. A large portion of that half of the brain has already sustained significant damage.
So can I see that catheter for a second?
Yes.
Can I actually touch it?
Oh,
I love touching, touching a little
it's all yours.
So this little toy, not so much a toy, but you could put this up through the femoral artery, find where the clot is, it must be in a fairly decent-sized blood vessel because
Yeah.
it's got such an area it's affecting, and then you can suck it out. Do you have to dissolve it first? And how does that really work when it's in there?
Typically, the dissolving occurs when Dr. Lechtenberg and her group organizes and administers TNK, which is that clot buster agent.
Yeah.
But once we get this thing in there, we just connect the back of it to this aspiration tank, and it's providing continuous aspiration, and like I said, literally sucking it. We can actually sometimes see the clot coming out through the tubing into this canister.
And is the goal you suck out all of it or most of it, or how much of it do you suck out?
Ideally, we want to get that main clot out.
Okay.
When we pull it out, there's always a small risk that small pieces will break off, go
Right.
further out. But it's better to have a smaller distal stroke than a larger, more proximal
Yeah,
stroke.
I can see that would really make sense. So how long does this take to do?
In some patients, if their anatomy is favorable, it just takes maybe 3-4 minutes to get from the femoral artery into the brain. And then another few minutes of aspiration, and ideally you're out.
Wow, and so that has got to be pretty. You guys who have been in this, for those of us been around medicine for a long time, our history is when we had nothing to offer, and we watched patients just stroke, and knowing that was going to be so awful. But this is a pretty amazing development. Dr. Abraham, talk to us a little bit about the methods in the SELECT-2 trial. I mean, we've talked about what you just did, but there are other things that our audience should know?
Yeah, so basically, again, it looked at patients who came in with a large vessel occlusion, so a major artery blocked in the brain, and those who had a large core stroke. So again, we saw that picture earlier, that CAT scan. And prior to the study, we would typically not enroll these patients because we didn't know if we went in and pulled a clot out, would that improve their outcomes, or would that increase complications or even death or hemorrhage into the brain. So those patients came in, and we talked to either the patient or the family, achieved consent, and then they would get randomized, just like flipping a coin, and they'd either get randomized to standard of care medical management, where we admit them to the neuro ICU, watch for brain swelling, hopefully they don't need a hemicraniectomy. And then the other arm was the endovascular thrombectomy arm, where we would take these catheters or other devices into the brain to pull out the clots. And we follow these patients all the way out to a year to see if there were better outcomes in the thrombectomy arm.
And so the outcomes. So as I understand, the patients got a thrombectomy had a much better outcome in terms of being able to walk and to be independent. Talk to us a little bit about that.
Yeah, so we looked at two main outcomes. One was what we call good outcomes. Those patients who may have some residual deficits but are able to live an independent life. So 20% of those in the thrombectomy arm had a better outcome versus 7% in the standard of care arm. So that was a very important finding that we saw from this trial. And then the second outcome we looked at is the ability to ambulate or walk independently. And 37% in the endovascular thrombectomy arm were able to walk independently at 90 days versus only 18%. And this is really, really important because if you cannot walk, that has such a huge impact, not just on the patient, but your loved ones, caregivers, maybe a home health nurse, because to get anywhere in your house or outside of the house, you would need somebody to help you. So to get from the bed to the bathroom, to the toilet, to the dining table, or to go to the front door, to go outside, you would need somebody to be pushing you along in a wheelchair or helping you out with a walker.
So Dr. Abraham, we think, well, we remove the clot, why don't 100% of the people, how come they're not able to walk?
Because, again, these patients come in with already a large portion of the brain that's stroked out. And part of it depends on which part of that brain is stroked out, because if it's really affecting the nerves that go to the muscles to the legs, then those patients may not be able to walk at 90 days.
So is it also a little time dependent, that the sooner you get there, the better off you are?
Yes, ideally with stroke, every minute counts. 2 million neurons are dying throughout a stroke every minute. But our study actually looked at patients up to 24 hours, and we still found better outcomes in the endovascular thrombectomy group versus the medical management group.
Dr. Lichtenberg, are we doing a lot of these?
Yes, last year in 2022, we did almost 200 thrombectomies.
And how many did you say you did yesterday?
I think we had 4 yesterday.
All right, so just 4 in one day.
Yeah.
And so this is becoming more and more the standard.
Yeah.
And how many places do this kind of thing?
Well, a thrombectomy should be done at a comprehensive stroke center, and there's 3 in the region. and there's 2 in the state of Kansas.
All right, so you have to get to the right place, which means you got to get to care, you got to get there fast and get transported really fast.
Yeah,
okay,
absolutely.
This is a big deal, folks, and I would like to introduce a survivor of this and someone who's really thrived. Michael Augustine survived his second stroke in February of 2021. Dr. Abraham removed the clot from his brain, and next to Michael is his wife, Sherry. First of all, thanks to you both for being willing to be a part of our program today. So thank you for being here. And Michael, thank you for participating in a clinical trial. You know, patients sometimes get a little scared when we start talking about research, but this is how we make such a difference in how we're able to treat care. Sir, your most recent stroke was just over 2 years ago. Do you remember what happened?
Not completely.
Talk to us a little. Go ahead. I'm sorry. Go ahead.
Vaguely, it was my wife got up in the morning to go down to make breakfast the way she generally does, and she was waiting for me to get up out of bed. And I tried to get up out of bed, and I stood on my right leg, and I just couldn't get balanced to stand up to walk downstairs. And she came upstairs wondering why I wasn't down there yet, and I was having a tough time, didn't really realize what was going on, but was struggling. Then I had the great idea of, well, if I lay on the floor, I can push myself up to stand up. I thought just my leg was still asleep or a pinched nerve or something. I didn't really understand what was wrong.
Yeah,
Well, when
that's
she came
hard.
upstairs,
Sorry, go ahead.
she came upstairs, then she got a little emotional and reacted. Go ahead.
Sherry, you were at home with Michael at the time. Tell us what happened at this point.
Yeah, so like you said, I was just going about my morning ritual, went downstairs to make breakfast, and he wasn't coming, so I went upstairs and couldn't figure out why he wasn't getting out of bed. And I said, do you need some help? And so I helped him get out of bed, and he went to the floor. And I just saw a look in his eyes and saw that he kind of started drooling out of his left side. And then I realized he was having another stroke. It had been almost 5 years, about 4.5 years since his previous stroke. So I knew there was that possibility. So I couldn't really think after that. So I called my daughter, who was just getting off work there at KU Medical Center. And so she said she would be right over. And when she came over, she checked him out, and she knew he wasn't able to move his left side at all. He had lost everything on his left side. So she said, just call 911. And we called 911, and it seemed like just within seconds they were coming down the hallway, and then we got him transported to KU Medical Center.
Do you guys, Sherry or Michael, do one of you remember about talking with Dr. Abraham about being about the treatment trial and the Select2 trial?
Yeah, I do a little, but of course, it's almost like a second language, like he's speaking French or something. So he was explaining, but I wasn't fully comprehending. And I looked over at my wife, and she was still a mess, kind of emotionally. So then I looked and saw Michaela was there, and asked her, said, do you understand what he's wanting to do? And she gave me that look in her eye of, yeah, Dad, I'm a nurse. And so I was looking for a bilingual, and so I asked, I said, do you think I should do it? And she said, yes, I think it'll really help you. So, okay, that's good enough for me. let's do
You
it.
know, I think all of us share this challenge that neurologists have their own language. You think they're in English, but really they're in neuro-English, which means they've modified the English language and invented words and phrases that no one else can understand, so they stay employed. That's how I think about how neurology has gone about it. By the way, eye doctors do the same thing, so do ear, nose, and throat doctors. Okay, Dr. Abraham, you brought some of the images of Michael's treatment. Tell us what we're seeing.
Yes. So the first picture that we're going to pull up. So Michael, this is the CT perfusion scan again, that specialized imaging, showing his several slices through his brain here, and that dark purple is the area that has already stroked out. So again, a large core stroke, what we see there. And so he actually had two things going on. In his carotid artery down his neck, the picture on the left, you can see where that red arrow is starting. The artery is severely narrowed because he had severe atherosclerotic plaque. So what I first had to do in that middle picture, you can see a balloon right there. I took a balloon into the carotid artery, angioplastied it, opened it enough to get the picture on the far right, and that allowed me to take my catheters further into his brain to aspirate the clot. And we see the picture on the left where the arrow begins. That's where the very top of the carotid artery, there was no flow past that. That's where the clot was at. And then you see the picture on the right. Now the flow has been restored to the entire right side of his brain after aspirating the clot out.
That is like super dramatic. What's that other big thing that other vessel was just to the left of the arrow before you?
Yeah, that's called the external carotid artery. That's the one that supplies the face, the scalp.
Now you look like that's just not as important. Man. That's not the brain artery. That's just the face artery. That's the brain artery we're worried about here. So Sherry, you were with Michael in the ICU, and you sent us the video of him moving his foot. This was just a few hours after thrombectomy. What was that moment like when you saw his foot move?
Well, there were several people in the room. I think there were some doctors and some nurses, I don't know, 5 or 6 people. And so they were trying to get him to move something, and when he started moving his foot, the whole room just cheered, and they were all really happy about that. So it gave us a lot of hope for what was coming up next.
That's a big deal, Dr. Lechtenberg, moving that foot early on like that.
Yeah, that's great.
So tell us what that means prognostically. Why is it great?
Well, we look for people to have improvement after thrombectomy, and it's great when we see improvement immediately after thrombectomy. And so that has a lot of potential for improvement. Kind of the more common thing is that people gradually improve, you know, in the days, weeks, and months to come with therapy and rehab.
So if you can start moving your foot in a few hours, you're like, okay, this could go pretty darn well.
Right, and sometimes we see a dramatic improvement where somebody who was plegic on one side and after thrombectomy, like almost immediately they can, you know, lift their extremities and have almost full strength.
Okay, so this was neurospeak again when she said plegic. That means you couldn't move one side.
Couldn't move one side, and then, you know, the clot gets removed, and, you know, there are favorable things that lead to somebody being able to move that quickly. But sometimes we see pretty dramatic improvement. Sometimes it's more slow and gradual.
So these, you know, these neuro folks, I have to admit, lung doctors do the same thing. I don't think we have quite the same language channel barriers, but this neurospeak is really just helps us get to the whole point right across to each other really fast without so many words. I'm a little more verbose, so I just keep yapping. All right, so the staff got Michael up, and he was taking steps in a matter of 3 days. Sherry, let's watch a little bit of what you recorded.
There's a good straighten. Okay. Good. Think really, try to make this hip touch the wall. Now think kick on this side. Yeah, good. Make that hip touch the wall. Yes, my good. Good, yeah, that's all you.
Okay, so without this treatment, would he have been doing that?
Unlikely.
And he would have not even been able hardly to support any weight on that left side.
I think it probably unlikely.
Yeah, that's a big darn deal. Okay, Michael and Sherry, talk a little bit about learning to walk again. What was it like at first, and where are you now?
I'm not sure my brain at the time fully comprehended that I couldn't walk. I think my brain was sending signals, so the brain thought there wasn't really anything wrong. But I knew I was going to the hospital to get something done. So I just thought, well, they completed their task and now it's time to get up and start walking so I could get home.
So you had to relearn more than just walking. What did you do in physical therapy?
There was a lot of the different strength. When they first put me on some of the machines, they would wrap my hands to the machine to keep my left arm on it and prop my left leg on it. So it was building up the strength. I didn't realize how much strength I had lost, but they worked really hard getting my balance and on different strength procedures.
Yeah, that's a big deal. Now, your stroke was February 25th, 2001, 200 days later, you were walking your daughter down the aisle. What was that moment like?
Well, that was a lot of the motivating factor for me walking in the hallways to try to walk, was so I could walk her down the aisle, because she had delayed her wedding a year because of COVID, so I didn't want any more complications from me causing
Sherry,
them.
what was it like for you to watch Michael and your daughter go? By the way, is that Michaela or is that a different daughter?
That's Michaela.
That's Michaela.
Oh, all right. So
she
this
was
is
the
the
one-
nurse.
Yeah.
All right.
She was the one
That's-
that came. She was the one that came over when I didn't know what to do when I first realized he was having the stroke, and she had just gotten off work there at KU Medical Center. So she's the one that she guided us through a lot of this stuff, because we were just not really thinking straight and didn't really understand everything. So she really helped us a lot.
So here's what I want to know. I had a daughter get married just over a year ago, and obviously I did not have a dry eye. Who cried first?
I don't think we cried. We were happy.
You're also happy, man. I would have been like bawling like a baby watching that whole moment, thinking about all that may have happened, but now what has happened, and such a contrast. And that's when science. That's when you say, okay. That's what we always say. You got to have some faith in the science, because we really work hard to make it right. So, how is your life today?
Good.
And are you able to get out and walk on your own? And
Yes.
So he used the cane for a little while, just while he was building up strength and building up stability, and gradually got rid of the cane, and he doesn't really use anything now.
With the daughter's wedding, it was outdoors, so I had the cane walking around just for extra stability, but I knew I wasn't going to use it while I was walking her down the aisle.
that's awesome. That's awesome. Dr. Abraham, Dr. Lechtenberg, okay. I don't know that I can keep a dry eye about this story. Maybe you can. How does it feel?
It feels amazing to see, this kind of outcome. I was telling them earlier that I was here the day that he came in the emergency room, and so I saw him when he had kind of these dramatic neurological deficits. And then I was off service, and I came back the day he was discharged, and I saw him before I was rounding, walking in the hall with with physical therapy, and it felt great to see such a good outcome, and it is even better that he got to walk his daughter down the aisle. We come to work every day, and this is our goal for patients every day, is to have good outcomes just like this.
It's like the Super Bowl, only better.
Yeah. Yeah, no, this is great. I mean, it is very touching. I have some tears building up behind my eyes,
Yes.
but it's just to see you walk down the aisle and just to come full circle. Your daughter and wife were there when you came in, and we really appreciate your trust in us to do these surgeries and then to trust us to do these clinical trials. And you're taking a huge risk, because it was a 50-50 shot that you could get the treatment, and you did. And and you look amazing today, and you were able to walk your daughter down the aisle, which is like the Super Bowl.
It is, and we've talked on this program many times about the intersection of faith, hope, and science, how it comes together and can produce what, for those of us who've been in healthcare a long time, feels like a miracle, because we've watched such bad outcomes for so many years. And I just hope people understand the impact of science on lives, and we're not in it just to try and make a lot of money on the device and stuff like that. That's not who we are. We are trying to help people, and this is a story that is a testament to the power of science, but with people who want to do investigation and patients who have the faith to participate in those trials so we can advance the science. And sometimes it doesn't work. A lot of times it does. And when it does, it just feels like a miracle. If you have questions for Michael and Sherry or our doctors Lechtenberg or Abraham, send them in to us on YouTube, Facebook, and the Medical News Network. Let's go down to Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control.
Yeah.
All right, Hawkeye, COVID count.
Yeah, it hasn't been good the last 2 days, unfortunately. 62 total, but 35 active. So that is up from the mid-20s, and again, still quite a good number of patients in the ICU, certainly more than we had been used to. 5 in the ICU and 4 of those on the ventilator, so quite sick.
I think this is Super Bowl party impact. Or right at that time period, though it would be. And, the national numbers are all trending down. The heat map looks better and better. But there's a little bit of a bump up. And I think it just is a reminder to us that COVID's still out there.
Yeah.
What was the highest number of flu patients we got to this year?
Maybe 30,
30, 35.
Yeah.
And here we have 60 whatever patients with COVID.
Yeah.
Please don't compare influenza and COVID. They are not comparable. COVID is much, much worse. And then, fortunately, we have an amazing vaccine. If you think about the influenza vaccine, Hawkeye, it's only 50% effective.
Yeah.
And these are like 90% effective.
Yes.
Thoughts about what it would be like if we only had a 50% effective vaccination for COVID?
We saw what we had when we had no vaccine. The 50%, that is what the original goal was, and we saw that it was so much better. It is just a different disease entity. That's true. It is the acute infection, but it's also that inflammatory stage that comes after that really causes a lot of that respiratory failure and the lungs not working correctly. So, again, I think we all continue to marvel at the vaccine, how quickly it was rolled out, the safety of it, and of course the effectiveness of it at really reducing severe illness, especially for those people that are high at risk.
Well, some developing news now from an FDA advisory panel that's going to be meeting today. This committee, Vaccines and Related Biological Products Advisory Committee, once again, we try and do a little medical speak. This committee is voting on whether to approve the first ever RSV vaccine for adults 60 years and older. We talked a little bit about that last week because New England Journal had a bunch of articles in there about it. We know there's already an RSV vaccine for kids, not for adults. I thought the data looked pretty good in the journal articles. I'm expecting a good result. What do you think?
Yeah, so yesterday we got the Pfizer, which was approved by this group, VRBAC, because of the reduction in severe illness, which was over 80%. And that is so vitally important because we see adults, people still continue to think it's just children, but it's not. It's those adults at highest risk. Today will be GlaxoSmithKline. Hopefully there will be 2 vaccines that people can choose from, especially if you're over 60, to help reduce that chance of severe infection.
I think this is approximately a very big deal, Hawk, because RSV is a difficult virus as well. It's interesting. For years, we didn't have effective viral therapy for most viruses, and now, between influenza, we do have RSV. We have some inhaled therapies for it, but they're pretty toxic. You have to give them in the hospital. Paxlovid for COVID. We've made progress here.
Oh, absolutely. I think this speaks to what we were just talking about the COVID-19 vaccines, how rapidly they were created. Of course, it was on the shoulders of a couple decades of work with the mRNA, but this was one of Barney Graham's first, and his goal was to create an RSV vaccine that we've been looking for 40 or 50 years. They've finally been able to do it, and it looks like it is effective. It is just another miracle of modern science, and what they've done is take one of the proteins that are on the outside of the vaccine, or on the outside of the virus, kind of like the spike protein, but they were able to keep it in a conformation which you are able to develop an immune response to, and that is what's causing that protection. You develop that immune response to that so that when you do see the virus, you have that immune response already there. It can kick in and help protect you from severe illness. So it's just, overall, it sounds really good, and if we have more than one vaccine candidate out there, I think that's great. Gives people the ability to choose as well.
And just to say, I don't think there's any day on the immediate horizon that Dr. Abraham's going to be able to suck out viruses from her body. Just kidding. Made that part up. Not even Star Trek would they do that. Live long and prosper. But but it is a pretty big deal that we, again, it's a demonstration of what science can do, people. It is the science.
And I think, to your point too, and it's not just elderly, but it is those immune suppressed patients like your lung transplant patients that you treat, our bone marrow transplant patients. If we can get this vaccine to them prior to transplant, give them some protection so that, when the respiratory season comes along, or if they are exposed to the virus, they will have further protection from hospitalization and, of course, severe disease.
Show me the science, people.
That's right.
It's really true, good stuff. All right, Jess, let's see what questions you got out there.
Yen wants to know, would stroke bring paralysis to both sides of our body? Why or why not? Why sometimes just one half, and could it ever be both?
Dr. Leitenberg.
It sure can, and it just depends on the location of the vessel occlusion and the part of the brain. So certain parts of the brain, you can have weakness on both sides of the body.
And Deb asks if we're doing pulmonary thrombectomies. She's been on Xarelto for 4 years to prevent new thrombosis, but old pulmonary thrombosis is still there.
Oh, that's a great question. I don't think we are doing a few, but there are some pulmonary thromboembolectomy true centers around the country. But I don't know that we haven't developed that as much yet.
Well, they do for acute pulmonary embolism. They do if it's very symptomatic, but on the chronic side, not quite. So.
Yeah, you can get an area I used to do a lot of practice in. There are a few places that will do chronic clots that cause what's called pulmonary hypertension. We could have a whole program around that, but and that's pretty remarkable therapy. There aren't that many patients that are like that, so there's only a few centers across the country. I think, I don't know exact the number anymore, but it all started from University of California, San Diego. They pioneered that technology and have developed. But acute strokes, or acute, what we call pulmonary emboli, lung clots, yes. More chronic ones, you got to go to the hands of the right people to do that.
Joellen wants to know if it's possible that Michael, our guest, suffered the stroke during the night, or are you able to tell if it happened during the night? And is there a time of the day that's more prevalent for a stroke to occur?
That's a great question.
Sure. I think it's very likely that he suffered a stroke sometime during the night. So with him, he was what we call a wake-up stroke. So he woke up and he had the symptoms. When he came into the emergency room on the CAT scan, he already had a large area of stroke. So that tells us that that stroke probably happened in probably the hours preceding when he woke up.
So some of his tissue clearly got rescued by getting more blood back in there.
Definitely.
Yep. Jess?
So last question, and it kind of is on that note, is it ever too late to do a thrombectomy? Is there a time limit that you need to get in there?
Technically not. This trial and actually another trial we were in, the Dawn study, looked at patients up to 24 hours. So if their CT perfusion scan has a favorable appearance, then we could go all the way up to 24 hours. And we actually submitted data for another registry Dr. Lechtenberg and I did, looking at patients outside of the 24-hour window as well. So we're waiting on those results. But up till now, technically, you can go up to 24 hours.
So what do you think? Can we go longer? Does it still make a difference if you go beyond 24 hours?
It depends. If the patient has what we call good collaterals, meaning other arteries are trying to keep that part of the brain alive, then you potentially could go past 24 hours.
Now, this has been This is a remarkable story, right? I mean, just to think about, I watched so many patients stroke out. You could do nothing. To see this happening, wow, what a big deal. So, just for my own and our audiences, folks, tell us about the team of people who you work with that allow you to take these clots out of the brain.
Yeah, so it's a great question. It is definitely a team effort. So, the first line of defense is Dr. Lechtenberg and the stroke team, who will get the call from anywhere, around the region, all the way out to Hayes, past Hayes, even southern Missouri, and then they'll let myself or one of my partners, whoever's on call, know, hey, we have a potential large vessel occlusion stroke coming in. And then I will activate the team when we have a good ETA, and the team consists of our anesthesiology colleagues. We have a tech and a nurse as well. So there are at least 4 people in the room in addition to the patient when we are doing these thrombectomy cases. And every person is very important and critical to the success of the procedure and the outcome of the patients.
And then back to the floor, you got the neuro team again out on the plus physical therapy, respiratory therapy. I mean, there's got to be a lot of folks involved. Nursing.
Right. On the post thrombectomy side, there's lots of different teams involved: neuro ICU, neurology residents, all the ancillary services. But I do want to comment, kind of even extending before our hospital, the partnership really starts with spoke hospitals, and these hospitals that we work with that call us, recognize stroke, know that there's treatments. Administer lytic quickly and transport the patient to us as quickly as possible. And then EMS's role in transport, recognizing stroke when they pick up patients. So that stroke chain of survival really starts, quite honestly, with patients and family members recognizing stroke.
In this case, Sherry McKellen.
Exactly.
Right. That's a big darn deal. Folks, let's get some final thoughts from our guests. I want to tell you what an inspirational story this has been, especially for some of us old guys who have been around patients like y'all and didn't see this incredible outcome in the past. So, Michael, let's start with you. Final thought for today.
We were just completely impressed with everything about the whole process. Everybody at KU was wonderful. Staff, from social services to the nurses, doctors, therapists, everybody was always very positive and just a wonderful experience.
Yeah, thank you. Sherry?
Yeah, I agree with that. We felt like even afterwards we were guided by people. There were people that were helping us to know what to do and to know what to expect in the future, and just things that we needed to be aware of after the stroke.
Yeah, well, it does take a large village. Dr. Abraham.
Yeah, I consider myself to be very blessed to be able to do what I can do and just to work with such great people. And again, to echo what I said earlier, to have the trust from our patients to allow us to treat you, allow us to take these risks and trying to help you out.
Dr. Lechtenberg.
I guess kind of just reiterating what we said earlier about it takes so many people involved in the stroke program, and many of them behind the scenes, to have outcomes like this and to see this kind of story, really makes it, it's important for all of us, working on the stroke program.
Doc Hogg.
Yeah, again, another good story. Always work with these fine doctors and their teams here. It's always great working with them and having collaboration. And on the subject of RSV, as we were talking about, we're looking forward to the meeting today to see ultimately what the committee votes for. But I think moving forward, especially for next respiratory viral season where RSV is more prevalent, this will be 2 things in our armamentarium that we can use to help protect those people most at risk from this disease. So I think overall things are looking good. And remember, as Dr. Stites always said, we've talked about other things this week going on, norovirus, things of that nature. Those pillars of public health go with you wherever you're at. So please remember to wash your hands as well.
So I am always impressed. I've spent really a lifetime in medicine, and having been able to watch where we started from and where we are today, it's quite the journey. Whether it's cystic fibrosis patients who don't have to cough, stroke patients who can walk, vaccine development in months instead of decades. These are amazing times, and it tells the story of what happens when we take care of each other and we work together well. It's not a red state, blue state question. It's a all of us question, working together to help science help all of us. Jess, back to you.
All right, Dr. Stites, thank you so much. Thanks to our guests and all of our viewers for joining us today. We'll see you back here tomorrow morning for another Morning Medical Update. Coming up tomorrow on the Morning Medical Update, chemo and radiation can have long-term side effects, and cancer survivors deserve long-term care. I'm Jessica Lovell on the next Morning Medical Update, the unique healthcare journey of childhood cancer survivors, and the doctor focused on keeping them cancer-free, Thursday at 8.
I'm Alexis Del Cid on the next All Things Heart.
And I had little fuzzies or floaters. I don't know if there's a medical name for it, but everybody gets them.
Floaters may be something you get and just blink away, but when Pat's ophthalmologist looked into his eyes, he saw something deadly. The connection between your eyes and your heart, and how a trip to the eye doctor saved a man's life. Thursday morning at 10.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.